Welcome to part 2 of 3 in our explainer series for Australian Dizziness Clinics, where today we're tackling 2 highly reversible yet incredibly frequently missed causes of acute vertigo. In the high-pressure environment of the emergency department, these 2 conditions are the ultimate metabolic and toxic traps. They completely masquerade as run-of-the-mill dizziness, but underneath that, they are quietly, relentlessly starving the brain. The good news here is that you can reverse them entirely. The bad news? Well, if you rely on standard clinical dogma, you're almost certainly going to miss them. Okay, let's dive right into this incredibly jarring clinical reality. When you're dealing with metabolic and toxic traps, waiting for confirmatory tests literally costs patients their brain tissue. Think about it. The patient with unexplained nystagmus and a history of hyperemesis or bariatric surgery will permanently lose their hippocampus if you wait for an MRI. So this explainer is all about acting before you confirm, because in these specific scenarios, the delay of a diagnostic test is the exact thing that seals a tragic, irreversible outcome. Now, what's really interesting here is how our focus today zeroes in specifically on the metabolic and toxic branch of vestibular emergencies, namely Wernicke's encephalopathy and carbon monoxide poisoning. Neurovascular events usually steal the spotlight in stroke pathways, right? But these toxic and metabolic culprits actually account for a massive proportion of preventable death and disability in dizzy patient cohorts. And here's the kicker. They both have class 6 triads that almost never appear, and they both require you to initiate empirical treatment based on clinical suspicion alone. So let's move to our first condition, Wernicke's encephalopathy, the missing triad. The absolute crucial point here is that this condition is routinely misdiagnosed as intoxication, or maybe a benign peripheral vestibular disease. What looks exactly like a standard case of drunkenness or vestibular neuritis is actually a critical, acute thiamine or vitamin B1 deficiency. This deficiency is actively destroying highly metabolic areas of the brain. We're talking the medial thalamus, the mammillary bodies, and the periaqueductal gray. The end result? Profound vertigo, severe ataxia, and oculomotor abnormalities. And this right here is the ultimate clinical pitfall. Medical training absolutely drills the classic triad into our heads: confusion, ataxia, and ophthalmoplegia. But the ED reality? Fewer than a third of patients actually present with all 3. Think about that for a second. That means if you're waiting for the full textbook triad to appear, you're going to miss over 66% of your Wernicke's cases. Isolated vertigo, unexplained unsteadiness, or honestly just nystagmus alone might be your only warning signs. Because the symptoms are so frustratingly nonspecific, you absolutely must actively hunt for the context clues. You need to immediately suspect Wernicke's if your dizzy patient falls into any of these specific risk categories. Yes, chronic alcohol use disorder is the classic one we all know, but you must also look out for patients with hyperemesis gravidarum, severe malnutrition, prolonged parenteral nutrition, and, this is a big one lately, post-bariatric surgery patients. If a patient from any of these groups shows up with new ataxia or oculomotor dysfunction, alarm bells should be ringing loudly. This brings us to what we call the MRI trap. While an MRI might show symmetrical T2 hyperintensity in the medial thalami and periaqueductal gray, relying on that scan is a massive mistake. These imaging findings are neither highly sensitive nor totally specific. If you pause your treatment just to wait for this MRI evidence, your patient's cognitive impairment could easily become permanent. You have to act before you confirm. Don't wait. So here is your empirical treatment first pearl. It's incredibly safe and it literally saves lives. Step 1, suspect it based on those risk groups we just covered. Step 2, give intravenous thiamine immediately. We're talking 500 milligrams 3 times daily for 2 to 3 days. And step 3, please remember this, it is absolutely vital. You must administer that IV thiamine before giving any glucose. Giving a glucose load to a thiamine-depleted patient without replacing the thiamine first, that will rapidly precipitate and severely worsen the encephalopathy. Let's transition to our second toxic trap, carbon monoxide poisoning, the oximetry lie. To understand why this condition is so deadly, you really just need to know this one number, 200. Carbon monoxide binds to hemoglobin with over 200 times the affinity of oxygen. It essentially hijacks the red blood cells, producing this profound tissue hypoxia that preferentially damages high metabolic tissues, like your central vestibular pathways. This means your patient's brain is literally suffocating on a cellular level, even if they're sitting right in front of you breathing perfectly normal room air. And here is the ultimate clinical pitfall when you're in the emergency department. If you put a standard pulse oximeter on a patient with carbon monoxide poisoning, it's going to give you a falsely normal or even high oxygen saturation reading. The machine simply cannot tell the difference between oxygen and carbon monoxide bound to hemoglobin. So, the crucial takeaway here is that you absolutely must use co-oximetry on a venous or arterial blood gas to measure the carboxyhemoglobin level directly. Standard pulse oximeter is a complete lie in this scenario. Now, because the clinical presentation is just non-specific dizziness, headache, nausea, and confusion, you kind of have to play detective. Before you brush off that dizziness as a benign peripheral vestibular disease, you need to ask about environmental clues. Are multiple family members feeling dizzy and nauseous? Is it winter? Do they have a faulty feeding system or maybe an enclosed combustion source like a generator? And here is the absolute golden question. Do their symptoms magically improve once they leave their house to come to the hospital?
Once you suspect it, treatment is swift and heavily protocol-driven. Step 1, immediate removal from the source. Step 2, flood their system with 100% oxygen via a non-rebreather mask to competitively displace all that carbon monoxide. Step 3, aggressively escalate to hyperbaric oxygen therapy if certain high-risk criteria are met. You absolutely want to consider the hyperbaric chamber if there are neurologic features, if the carboxyhemoglobin level is over 25%, if the patient is pregnant, or if there was any loss of consciousness.
Moving to our core clinical takeaways. Act before you confirm.
As we wrap up, we need to synthesize these two conditions into a single, life-saving clinical philosophy for your next shift. These are the takeaways you should literally burn into your memory today. 1. Waiting for textbook triads or perfect MRI imaging will fail your patients. They just don't happen often enough in the real world. 2. In suspected Wernicke's, empirical IV thiamine before glucose is what actually saves lives and preserves brain tissue. 3. In suspected toxic exposure, empirical co-oximetry, not standard pulse oximetry, is the only way to uncover carbon monoxide poisoning. Your vigilance, not sophisticated delayed testing, is the dominant determinant of your patient's outcome.
In Explainer 3, Infection, Trauma, and the ED Pathway, we close the series with bacterial labyrinthitis, meningitis, temporal bone fracture, and the unifying disposition rule every dizzy patient deserves. Thank you for watching this series. To explore more similar topics regarding dizziness, vertigo, and imbalance, and to access clinician and patient resource materials, visit AustralianDizzinessClinics.com. Please subscribe and leave a rating. Until then, I'll leave you with this thought. The next time a post-bariatric patient presents with isolated, unexplained dizziness, are you really going to let a normal MRI window delay a life-saving dose of thiamine?